Hello, everyone, and thank you so much for tuning into the Facilities in Focus podcast. It's always a pleasure to be a part of your journey on the internet. My name is Mackenna Moralez, and I am the managing editor of FacilitiesNet and your host of this very podcast. Today, I am joined by Travis Laird. Travis guides the creation of the University of Texas at Austin Specialty Hospital as part of the University of Texas Medical Center. Anchored by Dell Medical School, he collaborates with the senior leadership team to integrate care aligned with the clinical practice growth strategy, overseeing implementation of advanced technology systems, space utilization, and patient flow, and collaborating with clinical leaders on program development within the new specialty hospital. During his time, he has led or assisted in the capital planning and activation of 5 million square feet of hospital, emergency department, and outpatient service. Additionally, he has previously led non-clinical operations such as supply chain, protective services, patient support services, enterprise analytics, facilities, and estates in the project management office. Thank you so much for joining me today, Travis. How are you?
I'm great, Mackenna. Thank you for having me on.
A quick break to thank our 3 Season 5 sponsors, ABM, Orkin, and PointCore. Here's a quick message from all 3 sponsors. This episode is brought to you by PointCore, delivering facilities and construction solutions for healthcare that help organizations strengthen performance and support exceptional care environments. Pests hate us. Businesses love us. Orkin helps keep your facility ahead of pest pressures with practical, proven protection tailored to your needs. Healthcare facilities are demanding environments. Thankfully, ABM provides peace of mind with IAQ, efficient HVAC, and tech-enabled predictive maintenance. Learn more at abm.com/care. And now, we'll get back to the Facilities in Focus podcast.
Thank you. When I read 5 million square feet, I don't think people really understand how big that is. And so I was typing it out and I was like, oh, wow, that they trust you with a lot.
Yeah, I've been very fortunate to be a part of some 3 or 4 once-in-a-lifetime projects, if that's possible. So, and that's been spread across the globe. So, incredibly fortunate throughout my career to have been a part of some really transformative projects, including the one that we're going to talk about today.
Yes, and so just to give our listeners a little bit more context about what we're talking about, can you just explain the UT Dell Medical Center project that you have been working on and what to expect from it?
Sure. Yeah, so the project was announced in August of 2023 as part of the University of Texas system, of which 2 of the institutions within UT system are University of Texas at Austin and MD Anderson. So we're building a hospital in collaboration with MD Anderson. We've spent the past couple years understanding the market, understanding the needs of the communities across Central Texas, and we've landed on a tertiary quaternary care facility that will span about 2.5 million square feet. We're scheduled to see our first patients in the back end of 2030. We'll be focusing on complex diseases in cardiovascular disease, neurosciences, cancer care in collaboration with MD Anderson, as well as transplant. So one of the things that attracted me to this opportunity was the scale of the ambition and the really transformative nature that the university was thinking about this, not just as another hospital project, but really something that was a way to fundamentally rethink how healthcare was delivered and deconstruct and then reconstruct a healthcare facility that's fit for purpose in the age of artificial intelligence. So that was something that was, I don't think it's really being done anywhere, especially at the scale of which we're thinking about it. But it's really important to the community to Austin, to Central Texas. Right now, although there are some great doctors, the healthcare system in Austin is really fragmented. For being a capital city, for having a tier 1 research university like UT Austin, and to not have an academic medical center, it was a real opportunity to do something. I tell people there's no better time, there's no better place to do something like this than in Austin, Texas, as part of the University of Texas at Austin.
That is very cool. And do you feel like I've talked to lots of healthcare professionals in the last couple of years. Do you feel like this extra pressure when you are building a new facility?
Well, yes, there's always pressure, especially when you're talking about, a very expensive endeavor. Healthcare is a fixed cost business. It will continue to be a fixed cost business. And a lot of that fixed cost comes from the type of buildings that you build and increasingly the technology that goes into those buildings. So being good stewards of resources is really important to us. But ultimately, the responsibility that you have to patients to deliver on world-class care from day one. This isn't something where we can, have a soft opening and work the kinks out, and then expect to see, deliver world-class care. So there is a big responsibility. Like I said, I've been a part of major capital projects before, and so seeing firsthand the type of impact they can make on patients' lives, especially when they're viewed as a vehicle for innovation and transformation.
You kind of shocked me to my core just now. I don't know if you could tell that when you said it, but you are so right. You can't just do a soft opening when it comes to healthcare facilities. And I've probably said it like 1,000 times this season that healthcare facilities management is a very unforgiving job and that all these kinks need to be worked out well ahead of time. What is something that you make sure to follow through on every project that some other people might not think about?
Yeah, I think, technology as a buzzword gets thrown around a lot. And in healthcare in particular, because many organizations have these decades, if not centuries old legacies, where you're sort of bolting on different layers of technology or adding new buildings on a existing chassis, you sort of get to this, not necessarily Frankenstein version of a healthcare facility, but you sometimes lose what you're really there for. So we think about this through four very simple lenses, and hopefully every decision we make stands up to these four things. The first one is, are we fundamentally improving the quality of safety of care? If we're not doing that, then we shouldn't be thinking about some new technology or a different way to design a space. Are we improving the patient, visitor, and caregiver experience? Healthcare burnout is a very real thing. Improving the lives of the people that work in the facilities is really important. And then obviously extending that to the care that they give to patients to make sure they're at their very best all the time. The third is, are we improving efficiency? It's no secret that healthcare, particularly in the US, is incredibly expensive. A lot of that has to do with how inefficient the workflow is because of some of the bolt-ons that I was describing, because of the intense amount of coordination that requires caregivers to give across teams, particularly when you're treating sick patients. And then the fourth one for us in academic medicine, which is really important, is are we augmenting the academic mission? Are we contributing to impactful research? And are we teaching and educating the future workforce? So it's, once you boil it down to those things, you start to have a pretty clear decision framework on how to go about not just the design of the facility, but the equipment planning, the workflow design. What's the workforce of the future that needs to be, what are the skills that they need to have to be successful in the age of AI? So all of these things need to sort of come together into a harmonious and synchronized operating model.
And then the way that the facility has been described is that it gives the team a chance to start from scratch. How rare of an opportunity is that in healthcare, and how does it change the way that you approach operations?
Right. I would say incredibly rare. So this is the 5th Greenfield hospital that I've been a part of, but nothing to the extent to the quote unquote de novo extent that we're doing this. Right now at Dell Medical School, we have a small ambulatory practice. Most of our faculty work in partner institutions for their surgical or inpatient practices. So there's, the medical school opened about a little over 10 years ago. And so it's a very new enterprise, even though it's part of this large institution, historical institution at UT Austin, world-class institution. The medical aspect of things is really relatively immature as part of this journey. So we really view the academic medical center build as, sort of the phase 2 of the evolution and journey that the medical school has been on over the last 10 or 11 years. But the de novo nature, we have, alliterative differentiation, de novo, digital, destination, and dynamic. So those are the sort of words that we use to describe this project. And we've just gone live with a new electronic health record. We're installing a new ERP. Everything that we're doing is literally from scratch. All of the policies, all of the equipment planning. So we really don't have any historical legacy. It's not to say that this isn't still an exercise in change management, but we have the opportunity to look at every single component part that goes into delivering world-class healthcare, break it down, reconstruct it in a way, like we said, is fit for purpose in this future. Artificial intelligence, robotics, automation are really going to be foundational to that thinking, rather than another layer that we add on to an existing ways of working. So that de novo aspect not only goes from how we think about rebuilding or designing a healthcare facility, but what powers it, what information it uses. Ultimately, we want the building to be an intelligent and intuitive member of the care team that is anticipatory, proactive, and really giving back our clinicians the time and space to do what they like to do, which is take care of patients.
I think dynamic is such an interesting word to choose in it. What makes you decide some element is dynamic compared to others?
Yeah, so like you said, we're making decisions now on what a patient room looks like, what an OR rooms look like. Those are very difficult to change once they're built. They're actually very difficult, as you know, to change once they're designed. And so a question that we get asked a lot is, what are you doing to make sure that this facility and your operating model is not obsolete by the time you open in 2030? In 2030, only 4 years away, but as you know, the world is changing so incredibly fast. And that's a question that we ask ourselves all the time. So the word dynamic is really meant to signify we have to be thoughtful in our approach. We have to be flexible in how we think about delivering this project, because it needs to be done in a way that no project has really ever been done before. So dynamic is more about the mindset that we all have about the changing nature of our work, and accepting the opportunity to change, to grow, and to ultimately transform.
Mm-hmm. It is, I know, like you said, 4 years doesn't seem so far out, but when you think about it, that's someone's high school career, that's someone's college career, the toddler when it comes to age. We have to think about how rapidly things can advance. And right now in 2026, there's still a lot of skepticism that surrounds AI. What do you think it's going to look like in 2030, and how are you getting people on board with it right now?
Yeah, great question. It's no secret that healthcare has historically lagged behind, other industries when it comes to technology adoption and using technology to be more efficient, or using the full extent of a technological suite of tools that are at your disposal. So, like I said, ultimately, if we go back to those 4 lenses that we look through things, We obviously are engaging all of our clinicians in every decision that we make. And pilots are a good way to prove how something can be beneficial. So we've gone live in a couple of our clinics with ambient listening that can help a physician with their note and documentation. We had one doctor said, I've never closed all of my notes in a single day before. And so this technology has been really beneficial. So it's simple things like that they see the value and the benefit, not just to their time, but to the care that they're able to give their patients. I had a mentor who's a physician, once describe healthcare simply as an expression of empathy from one human to another. And that really boils it down to, people taking care of people. We talk about being AI native, but ultimately all of that is intended to do is to give back the human touch that we've kind of got away with in healthcare because of all the computers and the equipment and things like that. And so if we design this in a way that the systems are invisible, that really let humanity lead, then we think that we're doing something right. And again, systems that are adaptable and flexible. That even extending that care beyond the four walls of the hospital is something that we need to make sure that we're designing into the operating model today to be able to make sure that we're tethered to our patients, not just clinically, but understanding what's important to them, what a outcome that they would deem a successful outcome, because it's very different for every individual patient. The way to get efficient in healthcare in most industries has been through standardization. We think that now is the time and place to embrace variability as a strategic advantage. And when we say that, it's less about doing things differently every time, but it's more about understanding what's important to each unique individual patient, and then designing a care plan that is powered by the most significant and rich data that you could possibly imagine to give them the very specific, almost bespoke care experience that they would find meaningful to their specific circumstance.
Since you are on the operations side, how are you getting facilities teams to embrace this technology? I feel like they have been quite hesitant as well, with all the peace and love to my listeners. But
yeah, well, a lot of that comes down to leadership. We onboarded our chief facilities officer a little over a year ago in April. He's an amazing guy. We talk about the word dynamic. He's incredibly dynamic. He's a recovering naval officer. So we're proud to have Mark on the team. And, his attitude in the culture that he's building within the facilities team is just one that's can do,
right.
Can do. And that, you're right, we don't want to lose the discipline or design away the experience and knowledge that fantastic facilities operations teams bring to the table. But we can give them better information, and we can give them more information that is synchronized up with the actual operation. So, sometimes you have your building automation system over here and it's telling you some things. Then you have your clinical information over here and it's telling you which patients are doing well, which patients are not doing well. Then you have all of your other variables. What's traffic in the city like? What's the weather doing? All of these things can be brought together in a coherent and smart way to give not just the clinical teams, but the facilities teams a full picture of what's actually happening, and then offering insights as to how to intervene if needed, or make adjustments on the fly, or even weeks ahead. If we're looking at the surgery schedule 2 months from now, and we know that we're going to have, an air handler being under maintenance, those types of things that currently require so much human coordination. There's a way to do that coordination through rich data and smart and intelligent systems that make our teams even stronger, more efficient, and ultimately to be able to deliver the best care possible.
Mhm. We just had our software and technology season where we kept on saying AI is a tool in your tool belt. Don't be afraid to use it, but don't rely on it for
Yeah,
everything.
right. Yeah. I mean, it's right. There is, there's all of these conversations. We spend hours and hours, as you can imagine, across the 2.5 million square foot facility, thinking about how spaces were designed compared to how they should be designed with all of this. So, something like a nurse's station, or
Right.
more recently being called a multidisciplinary care station. Those are still really important because that's where people congregate. But
Mhm.
they're designed right now usually in a horseshoe or in a circle with a bunch of computers around it. So people are talking, but they're looking at a computer. So if you
Right.
have all of that technology, quote unquote, invisible, or to the extent possible, it's invisible and operating behind the scenes, then you're allowing the people to actually communicate and work together in a team in a way that's very fundamentally different than how you currently think about it today. Rounding is another example, how we teach residents and medical students. All of these, we look at every single part of a patient's journey in a caregiver's day or a staff member's day, and then thinking what should be human led, technology augmented, technology led. So things like supply chain,
Mhm.
the use of robotics is something that we're really leaning heavy into. University of Texas at Austin is a leader in robotic engineering. So we have all of these synergies across the university that allow us to tap into very specific domain expertise to design this healthcare facility in a way that is fundamentally different than what you would see in a current hospital.
I don't know if you can tell me this, but what's a design element that you are planning for the facility that you're excited about?
Well, I'm excited about everything. Like I
Good
said,
answer. Good answer.
um, but it's okay. What is the role of a robot? Um, and what will they be doing? Will they just be delivering certain streams of material? Will nurses have a cobot that follows them around and does tasks that nurses tend to do on a daily basis that are really non-nursing tasks?
Mhm.
We don't know a lot of these answers, but we're designing the facility in a nurse servers are a good example. So the place where a nurse stocks the patient's room from the outside of the hallway. So
Mhm.
generally that's done by a nurse. Sometimes it's done by a supply chain person. And we will have that capability for a human to do that. But we'll also have the capability or the design for the building for a robot to do that.
Right.
So, there's all these things where you don't want to lose the human touch of things, but you also want to make sure that the design doesn't forget about automation factors that allow the system to run much more efficiently. We had, if you can imagine, this concept of onstage, offstage, which was really about, what's patient facing and then what's service oriented. And sometimes it works really well that you design a corridor in the middle of a nursing station that is completely unseen, that
Mhm.
where all the services are done. We thought about that with the intention of that being sort of the robotic pathway.
Mhm.
Um, but the more we looked into it and using the expertise that we had at our disposal, robots will be likely able to navigate an environment much more intuitively than they would today. That's using some type of sensor or magnet or something like that. So like edge computing, giving a robot the ability to navigate an environment that's a mixture of human and non-human. So we have 10-foot corridors now in our design,
Mhm.
8-foot corridors. So it's just, you could go on and on about specific examples about how we've thought about existing codes or existing standards. Obviously, this will be compliant and it'll be, compliant with any code that you pick. But then what do we need to do to make sure that it has that flexibility and adaptability? All the patient rooms, for example, will be sized beyond what a current ICU is sized, not only to give the amount of space for the family member to be comfortable, but to accommodate any future equipment that we can't foresee today, but also being able to go to an ICU from a med-surg bed if we have to. So just pulling that flexibility and adaptability thread throughout every single conversation that we have.
Right. Right now, I'm just imagining like warehouse management systems and these nurses' closets that can automatically restock when needed.
Yeah. Yeah. It's, going from, there's a world in which the entire supply chain is automated all the way down to almost the last inch in which that supply is used. Definitely the last meter, definitely the last mile. So
Right.
All of these opportunities for us to design away current inefficiencies we're looking at. But I would say, something interesting that has come up is, on any given hospital, there's data that nurses in particular spend a significant amount of their time doing non-nursing tasks. So this idea of top of license. So if a nurse is doing 30 to 40% of their day on non-nursing tasks, that sort of means that we have 30 to 40% more nurses than you actually need. But when you talk to a nurse about their day, their critical thinking skills are off the charts. Nurses are the most creative workforce I've ever seen at just getting the job done, even despite many of the barriers that are put in place in front of them. But yet they do need that time where they're looking for an IV pole or they're trying to get a hold of a doctor because it allows them to decompress. So we don't want to design a system where they're just pedal to the floor for 12 hours a day. You talk about burnout. That's a recipe for burnout. So there's certainly a balance here with, making them more efficient and working at top of license without them completely burning out. So, including things like respite rooms or how, redesigning their job description to account for some of these things. They're all part of the equation when you think about activating a new academic health system.
Right. One of our facility maintenance decision columnists just wrote about how much time is wasted on the floor for facility managers. And he said that 18% of a facility manager's day is just like looking for stuff.
Yeah.
And maybe it's because I'm a mom too. I can't imagine how annoying that is to have to spend so much of your time just looking for stuff. I have to look for stuff all the time at home. I don't want to be looking for stuff at work.
Yeah, it is true. Yeah, you're right. Being a parent, a lot of your day is your child saying, I can't find something, and then you going to find it for them. But it is true, and it's very frustrating. I mean, wheelchairs are a great example. The wheelchairs get scattered throughout a hospital all the time. They're not tagged, so you don't really know where they're at. They're not trackable in a lot of cases unless they have an RFID tag. IV poles, the list goes on and on about the inefficiencies that go into delivering healthcare. There's thousands of pieces of equipment. There's thousands of people. There's thousands of policies. You talk about a complex environment. And so not just streamlining, but reducing the complexity of an individual's day is really important. And then you imagine a patient who is incredibly vulnerable, probably very nervous, including their family. And, you think about just how you give that, how do you reduce the vulnerability for a patient? How do you give them confidence in what you're doing? A lot of that goes into the facility design, but it also goes into, how we communicate with our patients.
Right.
And things like ambient sensing to not just understand what a patient's blood pressure is, but what's their emotional state? Are they feeling agitated? Is their breathing elevated? And those cues will allow the care team to maybe adjust their communication style, adjust their body language to be responsive to the person rather than the clinical issue.
Right. I have a question written down like this, but how much are you incorporating patient-centric design into this facility?
So I would say, to the extent that we can, be responsive to as many voices as possible. That's not just patients, but also the community, and of course our caregivers. I think the interesting thing about designing a healthcare facility is most of us have been patients, and we, you have that. If you haven't been a patient, then you've certainly had a family member that's been a patient, and generally, like I said, those experiences, you're usually there for a difficult reason, unless you're having a baby or something else that's a joyful part of life. But a lot of healthcare is very stressful and difficult to manage, and then you layer on the fact that it's a subject that not many people are well versed in. So a lot of what our clinicians are saying are really alien words to us. And so there's a couple of things that we're thinking about that we've heard from patients in particular, but also informed by our own individual perspectives, is this notion of patient-empowered communication, not just patient-empowered design. We do have mock-ups, and we bring people through and we say, here's the family zone. How do you like the family zone? Here's the patient bed. Here's the patient information board on the foot wall. Here's the TV. All of those things, getting patients' perspective is important. But the things they care about are, and this is borne out in patient satisfaction surveys, is physician communication, nurse communication, food, the quality of food, and then quiet at night. So quiet at night is an incredibly interesting one. Because of all the equipment, it's a very loud environment. There's things flashing. There's alarms ringing, and so hospitals have spent a lot of time thinking about quiet at night, and it's really important, and we are too. Alarm fatigue for caregivers is a big issue as well. But if you think about, if you've been a patient, usually a nurse will come in every 90 minutes to 2 hours, wake you up, take your blood pressure, take your temperature, or do some sort of vital check. So that can be very disruptive. And so if there's an environment that's doing all of that, and all of that clinical information is being automatically uploaded to the electronic health record, talk about a patient experience improvement, right? If you're not getting, woken up every 90 minutes to 2 hours for 7 days straight when you're trying to sleep, it can be very impactful. So it's little things like that we think will add up to be a really unique patient experience.
I'm going to cut this part out of the podcast, what I'm about to say. I just think it's a story that you might appreciate. When I gave birth to my son, he was a premature baby. I was the one that was sick. I mean, he was too because he was 6 weeks early, but it was mostly me. And I had to stay in the hospital for 6 days in the middle of a Wisconsin winter. You can't leave. They don't let you go outside. But this hospital was so good because they really did try not to wake you. But one of the rounds the round where I had to get my blood taken every morning was at like 4 a.m. It was super early. And for some reason they were told, don't wait, try not to wake her. Maybe because I just had a baby, or they were just being really kind in that moment. But I had to have an EKG done, and a woman walks in, and I woke up to her like unbuttoning
Oh,
my
wow.
gown, and I was like, "Oh no, no, wake me, wake me."
Yeah. Yeah. And it's a really great, and that happens thousands of times every day
Mhm.
across, hospitals all over the world.
Yeah, I would have been signed for patient violence because
Yeah.
it could have ended up bad.
Yeah.
But I'll actually start asking you questions I have written down. Travis, you've been a great interview so far, but you've been answering a lot of them. You're aiming not only to open a hospital, but to create a scalable model for healthcare. What would success look like 10 years after opening?
Yeah. Great question. I think there's a couple ways to answer that. First is that the level of care and the quality of outcomes not just rival, but hopefully exceed, the relevant benchmarks. So we're providing the highest level of care. As I mentioned, there's a significant amount of patients that, particularly if they have complex um, medical issues, they leave Austin and they go to the well-known places if they have the means to. And in some cases, unfortunately, the care just isn't here, so they go without care. So if we are keeping people close to their homes for the most complex issues that they're currently leaving the market for, I think that's a huge success. And that goes for the underserved patients, the patients that are currently leaving. This is really required, in our opinion, required capability that does not exist in Central Texas currently. So stemming that out migration and keeping patients close to home is a significant success metric. I think the other ones, you can imagine the patient experience that I've been talking about, making sure that we're delivering on that. And then this notion of what does the healthcare workforce of the future look like? What are the skills that they need to start learning now? And what are the skills that are coming that we need to be prepared for? Obviously, we're part of a university. We have world-class educators. We can be on the leading edge of what healthcare education looks like, but also ongoing education. So, did we rethink the healthcare workforce, and are we a national or global leader in how you train, upskill, reskill, not just clinicians, but every person that's part of the healthcare workforce? Our approach to what usually is called, a simulation center. This is a mock OR or a mock patient room where you bring teams together and you try out new things or you train together. We're rethinking that as well. So it's not just the clinical environment we're rethinking, it's the education environment as well. It's needs to be much more immersive learning. And then there's a whole conversation that we can have about the use of digital twins, not just for the facility, but for the actual healthcare operation that's running simulations, millions of simulations and helping to predict what is going to happen, in the next hour, in the next day, in the next week.
Right. And then I know I promise I want to take up so much of your hour, Travis, but I just have one last question for you. When you think about the legacy of UT Dell Medical Center, what do you hope people will say this institution changed about healthcare?
Oh, goodness gracious. What a good question.
I mean, a little heavy, but I feel like with healthcare, you kind of got us sometimes.
Yeah. I think that hopefully it's that we had a meaningful impact on new ways of working, that we accelerated the pace. We use this as a way to rethink research and accelerate the pace of discovery, and that the way we're educating the healthcare workforce is so new and novel that others want to come here and learn how we're doing it. But ultimately, our big thing here is putting patients first. That's what we start every meeting with. That's what we have on every presentation, putting patients first. And so that's the North Star. And all the decisions we make focus on putting that patient at the center of all of our decision making, our thought process, how we conduct research, how we educate medical students and residents, all of the things that go into the world-class institutions across the US and the globe today, particularly academic medical institutions. But just taking that puck and skating to where it's going to be and being a leader in that regard.
Well, thank you so much, Travis. I really appreciate you taking time out of your day to speak with me. Is there anything else you'd like to add?
No, this has been great. Thank you, Mackenna.
All right. Thank you. Thank you for listening to the Facilities in Focus podcast. Facilities in Focus is a product of the facility market, which houses FacilitiesNet, building operating management, facility maintenance decisions, and healthcare facilities today. Thank you to our sound and video editors, Paul Ellertson and Johnson Delapet. Thank you to Morgan Johnson for designing our logo. Thank you to Dan Welton, Dave Lubach, Dan Hounsell, Jeff Forden, Elena Myers, Corey Lallo, and everyone else at Trade Press Media Group. And of course, thank you, Dalton, Holden, and Baby Girl. It's always a pleasure to be a part of your journey on the internet. For comments, or if you are interested in being a guest on Facilities in Focus, please email me, Mackenna, at fnpodcast@tradepress.com.